Hello, my name is Stefan Kertes. I'm a physician in internal medicine and a researcher at the UAB Heersink School of Medicine and the Birmingham VA Medical Center. This talk is designed to introduce a scientific study that we are soon to begin and has been ongoing in pilot phase for the last 2 years, called Clinical Context of Suicide Following Opioid Transitions. At the time I'm giving this talk, we project that there will be funding that will come from the U.S. Department of Veterans Affairs Research and Development Branch with explicit permission to look at suicides that occur both among veterans and people who were not veterans at the time of their death. Before I go further, I want to introduce my co-investigators and partners. Crucially, on the left-hand side of the slide, you see me, Dr. Allison Varley, April Hogue, Adam Gordon, who are people who helped hatch the idea and support us in the process of seeking support to carry out this study. Also, we had the benefit of 3 suicide experts, including Dr. Thomas Joyner of Florida State University, the originator of the transpersonal theory of suicide. This work is inspired in part by personal collection of reports of deaths by pain patient, advocate, and Bachelor of Science in Nursing Ann Fuqua. And we have a partnership and support of co-investigators like Stephanie Gamble from the VA in Canandaigua and Megan McCullough in Bedford, Massachusetts. I also want to acknowledge right above my face here in the screen, TAPS, the Tragedy Assistance Program for Survivors, which has agreed to help us with identifying bereaved families who have lost a veteran or service member to suicide, as well as pilot funding from the Krulak Marine Alliance. A brief outline for this scientific presentation. I'm going to be showing the aims of the study, just as you would in a scientific report, challenges that we have to surmount in order to carry out the study, an overview of the methods for doing this work, some findings from the pilot study that we've been doing these last few years, and some lessons and plans going forward. And as always, if you have questions about this afterwards, I encourage you to contact us. If you become aware of people who have resources who would like to support our work, we will find a way to receive them, even if they can't go to a federal agency. We have all kinds of needs that will be necessary for this study to succeed. Let me offer some disclosures. At the time of this recording, the study is projected to be funding, actually hasn't been awarded yet. I have refused and not obtained any consulting or litigation income related to opioids or pain policy or similar matters where I've also been an advocate. I do own stock in medical equipment companies. My spouse has her own stock, and there were small pilot awards from both the Krulak Marine Alliance and UAB Heersink School of Medicine, which helped us figure out some of the tasks that we need to do. So let's go to the aims. The aims of this study are 2. The first is to characterize patient and clinical context factors associated with suicide among 110 to 115 persons, split roughly between veterans and non-veterans, who have died by suicide in the context of an opioid reduction. What was going on there? The second aim is to identify factors that may be unique to the suicides following these opioid transitions in veterans, as opposed to non-veterans, and among veterans who are in VA care, as opposed to those whose care was outside of VA. And as I mentioned at the start, when we applied for funding from the Veterans Administration's research branch, we obtained special permission to study deaths of people who were not veterans, along with those who were veterans. So why is this necessary now? I'm going to show this in the next few slides, but I want you to see the essence of this argument now. There's been a large reduction in opioid prescribing, both inside and outside of the Veterans Administration. The results of this change are unfolding in real time, and the evidence on its impact is mixed. Suicide among persons who are tapered or discontinued has public concern. But what is missing at this time is credible, actionable knowledge of the factors that can help to explain and prevent these tragedies. Just to illustrate the point I was making, there was a large rise and now a large decline in opioid prescriptions. This is from data as recent as 2020, presented by the Food and Drug Administration. Several studies have shown that for the subgroup of people on long-term opioids, there was a rise in the number of them who were subject to a discontinuation or a dose reduction. I'm showing 2 of those studies here, one by Neprash, used Medicare Part D, long-term opioid prescription recipients at 25 milligrams or more. They defined discontinuation as going to zero, and it was abrupt if they had a reduction from greater than 50% of their baseline dose to zero in just 30 days. In relative terms, discontinuations rose 49% between 2012 and 2017, and that's already somewhat out of date. And the percentage of these that were abrupt was always high, but it got even higher. Among VA patients, the study's a little different because it's looking at high-dose patients who were receiving over 90 morphine milligram equivalents, and the data is only current up to 2018. But discontinuation rose in relative terms 19%, and reductions in dose also occurred and rose in relative terms 28%. But outside of what these studies see is something really important, and I'm going to keep coming back to this again and again, which is that the context in which this happened, whether it was wanted or not wanted, the methods of reduction and what was going on in the life of the person is not seen by these kinds of studies. If one wants to understand outcomes from large papers that have been published to date, there are two summaries of mostly trials reporting on outcomes after dose reduction, predominantly in volunteer patients. One was reported in 2017, so it's a little bit out of date, but it's by Joseph Frank. They had 40 studies, including 5 small randomized controlled trials. And these were mostly short-term and voluntary and highly supportive. And they said, quote, very low quality evidence that opioid dose reduction may improve pain, function, and quality of life. And needless to say, in these trials, it was also achievable. But they specified that they didn't have much on safety outcomes. And in 2020, a re-review of the literature with some additional focus on veterans by Mackey showed that the net balance of benefits and harms of long-term opioid therapy reduction, taking all comers, was, quote, unclear. And it was also unclear for serious harms, including overdose and suicide. These do not rule out that this could be very beneficial for some, by the way. I've also looked at those large retrospective studies, a little bit like the ones I just cited, which look at outcomes after dose reduction, and they too have mixed results. In a review that we published as part of a commentary in June of 2022, there are 10 studies that detail some sort of adverse association between opioid dose reduction in a long-term recipient and the safety of the patient. These are retrospective, so they can't control for why it was reduced. The data comes variously from VA, Medicare, Oregon Medicaid. The outcomes studied vary, but include overdose, mental health crisis, suicidal events, and deaths, and these were often higher among those reduced than among those who were not reduced. However, one VA study carried out by Hayes and published in 2022 looked at an omnibus safety outcome that included new substance use disorder events and injuries kind of combined, and it found mostly an improved composite safety outcome, with some exceptions depending on how they did the statistics of the study. And one VA study found a rise in substance-related events right before and right after opioid discontinuation. And those authors said, look, there seems to be accentuated risk right after a stoppage for a substance-related event, but also right before too. So the story is a little complicated. These data were summarized by myself and Dr. Allison Varley in a commentary for JAMA Network Open, which you can pull open if you like using your QR code. And I just want to draw attention to 2 sentences. One is, our view is that opioid dose reduction is likely to offer benefit for some while harming others. The other sentence is, many aspects of the clinical story remain outside of the researcher's database, and that's pretty important to acknowledge when we want to answer a key question. Needless to say, some of these deaths have drawn a lot of public attention, particularly when there's a legal settlement involved, including these 2 that are reported, one from outside the Veterans Administration, one from inside. If the goal was to reduce risk, right now there is some guidance for people who are tapering opioids from different agencies. And generally this is what they tend to emphasize. Both the CDC, the Veterans Administration, and Food and Drug Administration suggest slow and collaborative tapers help to assure the safety of the patient. Studies from the Oregon Medicaid system and US Medicare are not 100% supportive of that aspiration that if it's slow, it will assure safety, which does not mean it is necessarily unsafe. I'm just trying to introduce a nuance here that's important. However, there is evidence of suicide and mental health crisis that can happen after slower reductions, too, for some patients. There's elevated risk of mental health crisis and overdose in some of those studies, and elevated mental crisis and overdose events even a full year after the reduction or the stoppage in a study published in 2022. So it's probably not just going to come down to how fast this is done. The question that we have is how to understand and prevent a suicide. That's our core scientific question. It's not how to change all of American policy. I have a different life where I act as an advocate, but this is how do we understand and prevent these suicides? And it's likely not going to be a question that is simply answered by looking at what happens at the pharmacy or on the prescription pad. So what I want to say here is what we don't understand about these large losses, these tragic losses, is very large compared to what we do. And to illustrate that, I want to provide an example from another field. So walk with me a little bit on this one. This is a different complex tragedy. TWA Flight 800 exploded and crashed 12 minutes after takeoff from JFK on July 17, 1996. It was a very widely publicized tragedy. A lot of people died, including some people who were quite famous. Many witnesses on Long Island said they saw a streak of light, possibly indicating a missile or something, going toward the plane at the time that it exploded. The FBI and the National Transportation Safety Board actually wound up at odds in the process of carrying out this investigation. And what I want to ask here is, what if we had studied crashes like this in the way that most researchers are carrying out opioid-related safety event studies today? Here's how they would do it. The first step would be to assemble a database of all the airplanes that went into the air. Then they would differentiate the ones that stayed up in the air, which would be, of course, 99.9% of them, and they would find a few that went down. They'd then need to find some standard data elements that could characterize all of those airplane flights, and that's available for all of those airplane flights. It might be the pilot's age, the aircraft's age, the recency of the maintenance, the weather conditions, how many people were on board relative to the thrust of the aircraft. It would be tough, but that's how they would do it. And then they'd run some sort of statistical model and say, we can now predict using predicted probabilities which planes are likely to go down, and maybe even target some prevention efforts based on that information. And that's really the seedbed of most opioid safety literature today. And I don't want to suggest that this wouldn't be helpful for studying airplane crashes. We really could learn some things that we don't know now by doing such large database analyses. But we also would likely miss a lot of things that were important. Because in point of fact, the way we currently respond to a complex tragedy like an airplane crash is pretty different, and it has something to recommend it. A complement to those database studies is case investigation. And I mentioned the National Air Traffic Safety Board before, the FBI. They all participated in the investigation of the TWA flight. They pulled the pieces up off the bottom of the Atlantic Ocean. And after studying them and running tests to figure out how planes explode if they're hit from the outside versus from the inside and where the explosion might have started, they concluded that this explosion was due to an ignition of flammable fuel and air in a hot and mostly empty center tank that caused the crash of this plane. And that led to new rules to help reduce the flammability of tanks going forward. And that's a really actionable insight that was arrived by studying cases in depth. And it's important to say that in suicide, we have a history of doing the same thing in the research realm. And these are called psychological autopsy. The first paper I know about that was published was in 1963 in JAMA, coming from the LA Medical Examiner's Office, looking at suicides individually. Obviously, one is not constructing a large database or interviewing the people who died. We don't have supernatural powers. You try to put together a story. Similarly, there are studies all the way going up to 2022 about these events, trying to draw lessons that can be used in clinical care. And there's a lot of things you can assess through psychological autopsy, and you can apply a different understanding than just what happened with the pills or what happened with the pharmacy. There's a model for suicide that's called the socio-ecological model. And it says, look, this is a complex event, and there are multiple influences, and we can inquire about them at multiple levels to understand why one particular death occurs. There are societal influences such as healthcare policies or understandings of those policies, firearm policies. There are community factors like whether the person is rural or urban, whether they're in a low or high resource community, what they perceive to be the availability of clinicians who could take care of them in their community. There are organizational factors that may include a local healthcare provider's policies on prescribing opioids or treating addiction or treating disability. There are interpersonal factors that are very important in the suicide literature, like whether people feel a sense of belongingness to their community, whether they perceive themselves as burdensome to others, exposure to suicides of others. And there are individual factors like the demographics of the person, their level of pain, their substance use history, psychological diagnoses, and even their overall distress, which in the suicide lit is called psych-ache, a new word for me. What could we learn by carrying out psychological autopsies of people who died by suicide after prescription opioid reduction? I'm just going to run through some examples, but I hope as you hear this, you'll think about other examples and send them to us. How many decedents had a rapid or slow opioid taper, and did they feel they had control over that? How long after the dose change was there any hint of potential for self-harm that anybody saw or heard? How many had psychological diagnoses? How many shared concerns with family and with friends? How many had risk factors for suicide such as perceived burdensomeness to others or a thwarted sense of belonging? What healthcare contacts took place before the suicide? Did healthcare feature conflicts or impasses in care with the people taking care of them? Was there possession of medication or a drug or a firearm? Sometimes that's referred to as means. For veterans, how many sought non-VA care or emergency department care? And what else should we be thinking about? I think my face is covering up the box, but we're interested. So having posed these questions, we've been actually working on the proposal for this work since late 2018, and we always expected someone else would start the study. And so I want to pose the question, why isn't everyone racing to do this study? And the short of it is this is labor intensive, and it's very high risk for the researchers. Witness that we had to apply several times to gain funding, and it's also expensive to do this work. And that's part of the reason we're going to continue to seek the insights and partnership and resources of all you out there and the partners that I've had the opportunity to brief. But let me cover some of the challenges that we had to surmount just in planning the research and in carrying it out. One is we have to recruit people who are survivors, friends or family who've lost somebody. Unlike most psychological autopsy studies, we can't just partner with a local coroner or medical examiner because there aren't enough of these deaths in one place. As a Veterans Affairs employee, we looked at the possibility of trying to tap a registry of suicides that are known. Those are available for clinical care and bereavement support services only, but not for researchers to go follow back and contact family members for research. So that's not off the table. What that means is we have to engage in outreach, and that's part of why I'm recording this talk today. It requires going to the public. It will require paid media, which we've tried out, unpaid work like we've done, and partnered work like with organizations that have a connection to people who have lost someone, such as the Tragedy Assistance Program for Survivors. But in beginning that process, the very first thing that one hits is fears and distrust, because people are necessarily going to be a bit skeptical of research on something so fraught like this. And there are legal concerns that people have about participating in this research, and people can be specifically skeptical about the VA. I mentioned this already, that with recruitment, we can't just partner with a single coroner. I'm not going to say more about that. But let's talk about distrust for a moment. In the process of preparing this talk, I tweeted that I was preparing a talk on this study. And somebody immediately posted a comment that said having the VA involved affects credibility. The VA continues to cut off pain patients, despite knowing it leads to patient deaths. Now, I'm not representing the VA here, but I noticed the individual took the time to create a graphic that they also tweeted that referred to a study from 2020. And the interesting thing here is it was published in BMJ, and it was a study that I was a co-author on, and where I played a role in helping to write up parts of that study, including the very limitations of it. But if you're going to embark in the process of trying to ask people to collaborate, job one is to be willing to answer questions, including frank expressions of skepticism. That's just part of the job I signed up for. I did respond. I said, look, I mean, I didn't speak for VA policy, but I said, look, VA-funded research is chosen for funding independent of clinical authorities, and the sole authority to publish lies with the investigator. There's no mother may I with publishing results. And that article from 2020 is one that was developed by VA analysts, and I was a co-author. That's what one can say. Other challenges. Retention. As people sign up to be involved in our research on the initial screening survey, they're not going to hear from us instantly. So there's a time delay from initial contact to when they can be engaged. And that requires a community preservation team, which is one of the reasons you actually need a budget to be able to keep folks aware of what's going on with the study. That's why we needed a grant. There's also data security. Anytime people impart information, regardless of whether it's covered by HIPAA or not, there has to be intense security around that. In our current design, veterans and non-veterans who might participate are initially engaged with parties outside of the VA. And that information can then flow into our VA server, not accessible by the non-researchers. It's tightly controlled just for the research team members who are approved by an institutional review board, no one else. But that's an inflow of information under tight wraps. There's also ethics and safety, a lot of ethics and safety issues that rise whenever you talk about suicide. I'm going to take you on a diversion on one of these questions that was a little bit curious and surprising in the process of our trying to get ethical approval. On our third review, one of our reviewers asked us for protection against something called the Werther effect, and I am pronouncing it in the German way. I don't know how many of you have tried to read the 1774 Goethe novel, The Sorrows of Young Werther. I really did try when I was in my 20s, and I could not continue it. But if you're curious, you can go on YouTube and search up the Lego animation of the same novel, which is actually rather cute. However, the story behind this is quite serious. Werther was a young upper-class German man who fell in love, and the love that he had was ill-fated and not meant to be satisfied, and it ended with him shooting himself. And when the novel was published in the late 1770s, suicides broke out in countries across Europe, and the book was banned because people seemed to be imitating the book. That's the Werther effect. And this isn't trivial because in 2020, a meta-analysis published in BMJ found that there's a 13% risk increase after media reports of suicide, looking at over 20 studies. A 2011 study found that the status of the decedent and how the suicide was actually presented really matters. So it can be presented in a way that sort of glorifies the person or in a way that makes it seem like kind of a sad, bad thing that kind of happened. So when Kurt Cobain died from Nirvana, there were suicides that happened at that time, people saying, I'm doing this because of Kurt. But at a net total level, the study suggests that there was no increase in overall suicide after that, in part likely because of how it was portrayed at the time. However, our response to the reviewer was not to say we're susceptible to the Werther effect. We're not publicizing a celebrity suicide. We're seeking volunteers who are willing to be work with us in a survey and an interview and helping get records if possible. And we said, look, that's been studied too. And in 2018 meta-analysis, most people who participated in a psychological autopsy study, usually an interview, had a positive or a neutral experience and had no regrets. Or even if they felt a little worse right afterwards, they would recommend involvement to studies to other bereaved individuals. That doesn't mean we have no responsibility for people in terms of how they cope after the interview, but it usually is not a risky thing to do. And we even asked Dr. Joyner, who's the editor of Suicide and Life-Threatening Behavior and one of the most prominent suicide researchers in the world, and he said to date there have been no events of suicide occurring as a result of participating in an interview about the loss of a loved one, given that these are trained interviewers and volunteers. Nonetheless, we still have a safety plan. When people do the informed consent for the study for the detailed interview part, we're going to give them an appendix that includes resources, and we'll do a telephone follow-up call or email to ask participants if they've experienced improved or worsened mood after the interview and if they need assistance. So let's turn to the methods of the study. This is a simplified overview. There's outreach, screeners, consent, medical record solicitation, and detailed surveys that are going to, and an interview. Those occur in parallel with two different groups. And then we try to synthesize the study of those cases. It's a case series to arrive at actionable insights that can assist health providers, health insurers, and health systems, as well as the families that are trying to understand what happened. I'm going to give you a detailed profile of this in just a moment, but I do want to mention the team structure for such a study, which is a little complicated. At the center of it all, there's a core investigator group with a principal investigator, and that would be me. We're going to have subsidiary teams, a recruitment team that engages in outreach. Some of that's going to be paid advertising, some of it will be informal media, some of it will be the continued maintenance of the community of people who engage with us. We'll have an interview team, which you see on the left, that's engaged in detailed interviews with survivors who wish to be interviewed. Just doing the initial survey doesn't commit one to be interviewed. Then there has to be a medical records team, which works with the survivor to see if they have authority to obtain and release a medical record. They may, or they may not, and that won't always be surmountable. And then there are consultants and collaborators who have to advise us. And that's part of the reason we're doing these briefings, is while there's a formal, smaller group of patients and family members and scientists who will give advice to the study, we believe that others out there, like yourself, might have ideas that could help us think about doing the work as best as we can. Let's turn to a slightly more detailed overview of how this study works. The first box that you see in A is a little bit pink in color, and it's meant to suggest that it's not exactly from within the Veterans Administration or from the university I work at. There's a public-facing and targeted recruitment process, which will involve advertising, as well as posting information about the study in Facebook groups that are interested in pain or in suicide. Some of this, as I'll explain shortly, we've tried out. We'll have to issue a contract to a commercial outfit to help advertise the study, as well as work with community collaborators. People may engage with a short pre-screener, probably 5 to 8 questions, and we've tried this out. It was 8 questions in our pilot, and if they wish, they can continue on to a more detailed screener. And that more detailed screener is a survey. It can be done online or by phone, and it's handled at the University of Alabama at Birmingham Recruitment and Retention Shared Facility, and it's stored in a hyper-secure, multiply accredited REDCap database, and it has about 44 questions, as I recall. People there it'll become easier to clarify both some information about the death, whether people are really interested in participating in further research, which means they're going to be invited to do more if they wish, and if they're not, they can actually sort of leave at that point. For those people who are interested in being contacted, there'll be a follow-up to do a detailed informed consent. There's actually informed consent for the other 2 screeners, but it's just by clicking through the survey. But the detailed informed consent involves a signature, a lot more information. I have to note that there's some thunder as I'm speaking to you. And then a follow-up survey. We'll work with them to identify where and if medical records can be obtained using a unit at the University of Alabama at Birmingham School of Public Health. We'll have a separate team review medical records to code to look for things like what happened in care that was known by the clinicians and that was documented by the clinicians. Conversely, we're also going to interview survivors, and there's room to interview 1 or 2 survivors for each person who participates. If necessary, we'll go to 3. These may be friends and they may be family. Obviously, if they're close friends, we understand that they may not have power to release a medical record. That information has to be piled together, both the transcripts of the interviews and the findings from the medical record review, to create a portrait of each of these deaths and to identify points of action. And again, I do apologize, my head is covering the bottom right box. Just so you know, we've piloted 2 of these steps. With the green box, I'm going to introduce the pilot number 1, which is still ongoing. And there's a little white box I just added in there that's pilot number 2. Starting in November of 2020, we began with social media posts that I put up and Ms. Fuqua put up and Dr. Varley put up saying, have you lost someone with pain to suicide? See our survey. We have the name of the study there. You'll notice the name of the question that's used doesn't emphasize opioids exactly. It emphasizes pain. We had different images, sometimes veterans, different races, not always veterans, and our mission statement. We want to learn how to prevent those deaths from happening. That's our mission. And then a web link. That was pilot study 1, and it actually is the detailed screener that I referred to. In late 2021 and early 2022, on a time-limited basis, we engaged an external research recruitment firm called TrialFacts to give a shot at trying to recruit using their advertising and their database. They used YouTube and Craigslist and outreach. They didn't use Facebook, in part because there were some difficult rules to overcome in spreading the word about this study on Facebook. So for given the money and time available, we didn't try that one. Just again to review, the public-facing recruitment that we tried out was the shorter thing that we only did for 4 months, and there were only 8 questions in that, but people could then progress if they wanted to the thing we started in 2020, which is the detailed screener survey. Some pilot findings, and I'm going to be speaking primarily about the results from the detailed screener, some of which came through the TrialFacts pilot, some of which didn't. 316 people appear to have navigated to our screener, 200 and engaged with it. 220 passed 4 pre-screening questions. The first of which is, do you think somebody close to you died by suicide after a reduction or change in opioid prescriptions? The others were about their age and where they live. Again, some thunder. 94 did not pass. 62 were willing to be contacted. And of those, I'm going to show this in a moment, but about 14 were veterans, 4 left that blank, 47 of the decedents were not. 158 either didn't endorse being willing to be contacted, or they left that item blank, which means they didn't get to the very end. So they might be people we could follow up. A little bit of summary data. 55 of the 62 said they were very confident the act of death was an intentional suicide. 22 described opioids being reduced. 39 said stopped. We allowed people to say it was increased, but that was a pretty small number. 18 had legal authority to request records, and 11 were veterans. I've looked through a lot of the comments that people left in the free text portion of this pilot, and we haven't formally analyzed them. The stories vary a lot. Respondents' attributions of why the death happened don't always turn on what happened to the prescription. Sometimes they say, well, the prescription went down, but there was another family event that I think really caused this. There are people who describe illicit drug use along with prescription opioid use together. So the stories are really variable, even from the brief comments people have provided. Our detailed screener still is running right now. So if you are aware of one of these deaths or you know somebody who's lost somebody, they can go to go.uab.edu/CSI opioids and give it a shot. That's what they're going to see when they go to that page. So let me summarize. 8 to 11 million people in the U.S. receive opioids on a long-term basis. Trials will clarify, not our study, trials will clarify better and worse ways to taper in volunteers, and those trials are ongoing. Under real-world conditions, however, actual reductions, as they're really happening, are, we think, helpful for some and harmful for others. Suicide merits a much deeper level of understanding than has been brought to bear to date, and we do not think it can come simply from mashing large databases and looking for standardized data elements. Remember the graphic I produced of studying airplane crashes that way. This study aims to deliver that understanding, and we do wish for your insights, your advice, and we hope and expect resources one day, even though we will get started soon with funding from a federal funder. With that, I'd like to say thank you so much for your attention, and we're delighted that you've paid attention to this video.